welcome back to our series where we interview people from the hepatitis C community. My name is Carrie, and I'm back again with Daryl.
Hi, everyone, and welcome again. Today we have Nance Cunningham with us, who has a Master of Science from Johns Hopkins and is currently working on her PhD here in UBC. Hi, Nancy.
Hi,
welcome.
Nice to be here.
Good to see you again. And can you tell us a little bit about yourself and your work and introduce yourself?
Yeah, thank you. I am actually fairly new to hepatitis C work. I first started working in hepatitis C about 3 years ago when I spent a year working in Pakistan on a project in Karachi that had a hepatitis C clinic in it. And during the time I was there, it switched from being a public health care clinic with the hepatitis C component to being a pure dedicated hepatitis C project. And before that, I'd worked in quite a number of other issues, including HIV. And it really struck me with hepatitis C how clear and simple the path to progress was compared to a lot of the other things that I had worked on, which are much more complicated, difficult to cure, difficult to treat. And so I really became enthusiastic about hepatitis C because there's such a great cure and there's such a great test, and it seems like there's not really that big of a barrier to just curing people and being done with this disease.
If it were only that simple, Nance.
Yeah, well, it's not that simple. And that's how I ended up here at this PhD program. So I started thinking about it more and more and realizing how difficult some of the barriers were to deal with. And that's why I just decided that I wanted to get into it a lot more deeply. And I applied to UBC to do a PhD, really looking at what the barriers to access to hepatitis C treatment are.
So that's a pretty perfect segue into what brought you into doing hepatitis C work in the first place. And you kind of mentioned transitioning out of doing work involving HIV. So tell us more about what brought you to the work that you're doing and just kind of formed that experience or that desire to learn more and do more in the hepatitis C space.
So like I said, I felt like it shouldn't be as difficult as it seems to actually be to deal with hepatitis C. And so I realized that I really needed to learn a lot more about it, and that there were like many levels of depth that I had to understand in order to really be able to understand what the barriers were. So I feel really lucky I got into UBC. I'm in a great team, but they are mostly working on administrative data, and I am used to working more like in the field and with people. So I was really lucky to meet Pacific Hepatitis C Network really early on in my stay in Vancouver. And I immediately was like really impressed by what they were doing, all the connections that they were making with individual patients. And I started talking to Daryl and Deb and other people in the area who were interested in hepatitis C. And what really jumped out at me very, very quickly and very clearly was that people's main concern was how they were stigmatized when they went to get care. And I think before I got here, what my supervisor had told me and what the general impression was before I got here was that the main issue was access to care. But then between the time that I applied and the time that I actually arrived, then actually everyone in British Columbia had access to hepatitis C care if only they would go and get it. So that was like the main thing people had been concentrating on before, right? Was this just to get everyone access to care. But then it turns out that when care is available, people are not streaming in to get cured. And so then the main issue becomes, why not? And what I found talking to people is that one of the main reasons why not is that they don't want to face the stigma again that they have faced before in the healthcare system when they're not dealing with a disease that's gonna, that it doesn't necessarily hurt and it's not necessarily going to do them harm within their, within the next couple of years. So it takes a lot more urgency than that for a lot of people to overcome the stigma that they've experienced before and to go and actually access life-saving care.
So you see a definite disconnect with how Hep C care treatment is provided here. And it's not unique to British Columbia, of course. You certainly seen through stigma and other barriers. There has been, of course, examples of rationing of care with hepatitis C.
Yes, absolutely. And that's something that I never saw when I was working in Pakistan. There it was very clear. First of all, there was very little or no stigma involved. People would be tested and they'd be like, oh, I have this? Sure, I'll have treatment. And they would start treatment within weeks usually. And it was very clear if someone did not clear the virus the first time, they were going to be treated again. And if they got reinfected, they were going to be treated again. And I was honestly really shocked when I came here and found that people were being told that they could only be treated once, for example. And that is, it's just not right. You can't just let somebody die or be, seriously impaired by a disease just because the first treatment has failed them. And not only that, but you don't even really know if it was a failure of the treatment or if it was a failure of the healthcare system. You cannot just let somebody suffer because they were failed in some way.
That's a great point. It's I've always framed treatment failure as treatment failure. The treatment has failed the person.
Yeah.
The person didn't fail.
Absolutely.
In that.
I read the policy as well. I had first heard that people had been told that they could only be treated once, and I read the protocols myself, and it's very clear. It's down there in black and white that people can be treated until they are cured. But somehow there are treaters who think that it's a good idea to tell people that they can only be treated once.
And again, I think that's the stigma, and you would agree, I'm sure.
I don't know yet what's going on, and I am hoping to talk to healthcare providers. Right, I've talked to a lot of treaters, but they are the sympathetic treaters. These are mostly people who started out also working in HIV and are now expanding and including hepatitis C in their care. And so they have a very different and very compassionate attitude. I haven't yet talked to any of the treaters who have told people who have restricted people in any way, who, for example, would tell people that they have to get off of all kinds of substances before they can get treated, or that they cannot be treated a second time. I haven't talked to any of them yet, but over the course of my PhD, I actually do plan to talk to people and find out what is making them make that kind of a statement. I'd like to hear it from their perspective.
Yeah, where I hear about it is from the community. As a person myself with lived experience and working in the community, that's where I hear about it.
So I think that, no one becomes a doctor because they want to make people's lives miserable and choose who gets to live and die, right? People become doctors and nurses and pharmacists because they really want to help cure people. And I think that there are other reasons why aberrations like this come out. And until you find out what they are, then you just have to wait and suspend judgment. It's very clear that people need to be treated until they're cured, and that there is no justification for a physician deciding whether or not somebody should get the hepatitis C treatment in British Columbia at this time. Everyone is eligible and everyone should get it as many times as they need.
I just want to rewind a second, because I think you touched a little bit on your work abroad, and I wonder if you would share a little bit more about that work that you did outside of Canada with us, because I think you've contrasted some of the perceptions around hepatitis C between Canada and Pakistan very nicely, but I would be interested to hear more about some of the experiences you've had outside of Canada with regard to hepatitis C.
Yeah, I'd love to tell you about my work in Pakistan. So I was there for about a year, and I was in a clinic that had already been open for about 5 or 6 years. They were treating hepatitis C first as part of a primary healthcare clinic, and then later as a completely dedicated hepatitis C program. So I was working with an organization that had an open door policy. So anyone who came in and asked for treatment or asked for testing was tested and then eligible for treatment. But I realized that as long as we kept just waiting for people to come to us, we would change the lives of those individuals who came to us for treatment, but we were not really going to make a permanent or long-term difference in the community that we were working in. And it just happened that we were working in a community that did not have a lot of people who were coming in and out of it. So it was a really good situation for micro-elimination.
All right, so we are back from some brief technical difficulties from Nance, and so Nance has turned her video off, so hopefully the audio is still able to come through loud and clear. Before we broke off for our tech solving break, you were about to explain about micro-elimination.
Right, so micro-elimination is an idea that's been around for about 5 years now. The idea of elimination itself is much older, but micro-elimination is the idea that instead of trying to tackle like a whole country at a time, you can eliminate hepatitis C in a network of people who have the potential to infect each other. And that way, even if for various reasons the risks of transmission still persist, like where we were working in Pakistan, for example, we think that that was a lot of maybe unsanitary medical procedures, and also we thought some people might be getting it through their occupational hazards. But even if they couldn't avoid those behaviors, you can still avoid hepatitis C because everyone has been cured of it at the same time. And because this community didn't have people moving in and out of it very much, that means that you then are free of hepatitis C for quite a long time. And even when it gets reintroduced, it'll have to start all over again, and it will spread only very slowly. So two colleagues and I really worked on a plan to try to do this in this particular part of Karachi. And actually that plan is actually just starting now at the time that I am unfortunately no longer there to take part of it. But I'm really proud of what my colleagues have done, and it's going to make a really big difference for about 150,000 people in this informal settlement area in Pakistan. But what we did when I was there is we started out giving it kind of a pilot test by going by occupational groups. So what we figured was that people who were working in the fishing industry would be handling a lot of sharp things, including knives. There are scales, there are the shells of shrimp. There are lots of places of opportunities to get small cuts on your hands, for example. And then you're handling things and you're passing them back and forth. So that's like a really easy way to transmit a virus like hepatitis C that only needs a very few number of viral particles into your bloodstream in order to infect you. So that's what I started when I was there. We went to fish packing factories, and we talked to the owners and got permission to suspend their operations for a short time. And then we would go and talk to the entire factory workers, the whole population of factory workers, explain to them about hepatitis C, and then invite them to get tested. And every single person would step up and get tested. And then we were able to cure an entire factory worth of people who needed it at the same time. It was really exciting.
Yeah, that is.
That's really cool.
That's really great, Nance, about micro-elimination. Clearly, there is a place for that work here in British Columbia and elsewhere.
Learn more about viral hepatitis and the BC Hepatitis Network by visiting bchep.org and contact us at podcasts@bchep.org. You can also find us on social media via the links in the show notes. For more episodes, visit bchep.org/podcasts or subscribe on YouTube or your favorite podcast app.